Okay. So can you all see that? Just say something because I can't see any of you anymore.
Yeah, we can see it.
Okay, fantastic. I'm just gonna, this is reminding me of COVID because during COVID I had to teach online and I couldn't see anybody while I did it. So let's talk about anxiety and depression among cancer survivors. This is an area that I've been researching and practicing in since about 2011. So it's been a while now. And I feel very passionately about this because I think these symptom groups are often overlooked and misunderstood in this population. So let's talk about what we're going to talk about in our webinar today. So to begin with, I want to ask the question of how do we understand these phenomenon? Who are we talking about when we are talking about anxiety and depression among cancer survivors? Hint, it is not everybody. In fact, it's not even most people in terms of clinical significance. And then what do we do to detect anxiety and depression? What are best practices that whether you're working, in hospital accreditation or distributing cannabis to folks undergoing cancer treatment, it's really good to know what are the gold standards for even determining who's anxious and depressed and at what threshold, and then what do we do about it? And what can you do about it regardless of whether you're a mental health professional? So first I'm going to start with what do anxiety and depression look like broadly, and how do they express in cancer? So here we have this cancer survivor, and you can see from the photo, this is an alleged cancer, this is a theoretical cancer survivor. She's relatively young, and that's not mistaken. Age has an inverse relationship with anxiety and depression. So the younger our patients, the more likely they are to have significant mental health sequelae of cancer. So she's asking, why am I crying now? Um, and this is after treatment, right? She's done with treatment, she's gotten through, but all of these questions are now arising. Who am I now? My friends and my family don't get it. I should be doing more. Why am I slowed down? I can't keep up at work. I'm exhausted. My brain is foggy. I feel abandoned by my medical team. I was coming in every week for chemo, and now they say, see you in 6 months. And who's going to support me in those 6 months? And how am I going to know whether things are going okay? And then what if this thing recurs, right? And of course, this is really a picture of folks who have been treated for early stage cancer with curative intent, with the intent to be cured. Um, we'll talk about folks with metastatic cancer in a bit. Um, so these are really common concerns, and I want to tease out the anxiety and depression pieces here. But before I do that, I want to put out there, as somebody who started out for many years as an anxiety researcher, let's just look first, what is anxiety exactly? These will sound familiar to most of you, but it's helpful to really pinpoint. So anxiety is a future-oriented mood state to prepare for possible upcoming negative events, to prepare for future threats or possible threats, right? And there are three main groups of symptoms in anxiety. The first is cognitive, right? It's repetitive, ruminative worry about the future. The second is avoidance. It's avoiding behaviorally anything that makes us anxious. And our research shows that can include healthcare appointments. And number three, in kind of more generalized forms of anxiety, it's muscle tension. So holding the body very rigidly and very tightly, very common. Now, I want to differentiate anxiety on one hand from fear and panic in the other. In all mammals, we can differentiate these, and I will illustrate that next. But let's talk first, what is fear and panic? Because our patients and we often throw these words around, and they don't actually mean the same things as anxiety, technically speaking. Fear and panic are when we're in immediate danger. The car is barreling straight towards us on the road. And that experience is a little bit different. We have thoughts of, oh my God, I'm going to be killed, or oh my God, something horrific is about to happen. We try to escape the situation if we can. And we experience physical symptoms of panic, which include things like sweating, trembling, heart racing, nausea, tingling, vision changes, dizziness, and more. So the proximity of danger matters for what people experience. So here is the oncologist saying, I hate to say it, but the scan shows that your cancer is back, right? That is a moment of panic because the danger is very close. And our patients certainly experience that. And we as humans experience that. But what most of our cancer survivors experience is something more akin to anxiety or worry, is the ruminative thought, what if my cancer comes back, right? The danger is far away, it's remote, but it's a possible future threat. Okay, and so this is kind of how we distinguish between anxiety and worry. On one hand, when danger's far and remote, and the danger is upon us right here in this moment, and that is fear and panic. And they are a bit distinct in terms of what people experience in their bodies and in their minds. And then what is depression exactly? I'm sure we all have a sense of this, but just so that we're all on the same page, core symptoms of depression includes thoughts of loss or failure, very, very common, of course, among cancer survivors, energy loss, and withdrawal. Okay. Now, of course, if we're talking in the DSM-5, the kind of book where we turn for criteria of psychological disorders, a major depressive episode has more symptoms to it. But what's important is that the core required symptoms for a depressive episode are either depressed mood, so sad, numbed out mood, or loss of interest and pleasure in things that normally would bring them to you, which is known as anhedonia, most of the day, almost every day for 2 weeks or more, plus a whole other number of symptoms, which frankly overlap in the case of diminished concentration and later appetite loss or gain with side effects of chemotherapy and other cancer treatments. So now let's apply these to cancer survivorship. So it's important for us all to know that the majority of cancer survivors do not actually meet criteria for a full-blown anxiety, mood, trauma, or even adjustment disorder. So most people go through cancer, even treatment for metastatic cancer, at least in the US context, because these rates tend to be much higher in countries where there's less support for cancer survivors. The majority of US cancer survivors don't actually meet criteria for a DSM disorder. However, when folks are stuck in hospitals, a really high portion of them meet criteria for an anxiety or mood or adjustment disorder. And even when even when cancer survivors don't have a full-blown disorder, a very large number of them have elevated symptoms of anxiety, of depression, of future-focused trauma symptoms, kind of anticipating traumatic loss. Those symptoms are very, very common. They tend to be higher among female cancer survivors, younger cancer survivors. So I know at least one of you works with young adult cancer survivors. That is our most vulnerable group because, of course, cancer is the least kind of typical for younger adults. And these rates tend to be higher in late-stage cancer, which makes sense because the degree of threat is much greater. The thing about anxiety, so differentiating anxiety from depression for a moment, anxiety is really the psychological legacy of having had cancer because anxiety is super common and it's also incredibly chronic. So it is what meta-analyses show is that anxiety can endure for more than a decade after cancer treatment. When they compare cancer survivors with non-cancer community controls, anxiety is higher on average among cancer survivors, even a decade and more after cancer treatment. And by the way, the same is true for cancer caregivers, are often overlooked unsung heroes. The most common form of anxiety among cancer survivors is fear of cancer recurrence or progression. And that is super common. Up to half of folks experience moderate to high levels of fear of recurrence or progression. But also common, of course, are existential forms of anxiety and PTSD symptoms related to cancer, although full-blown PTSD is actually pretty rare among cancer survivors, at least as it relates to cancer. Now, why should we care other than wanting people to live fuller lives? Well, we know from a lot of research that high anxiety among cancer survivors predicts lower quality of life, overestimating their risks and the risks of engaging in further treatment. So they might quit tamoxifen early because they're overestimating how risky it is, because they're really attuned to threat. They tend to over and underuse medical care. So they tend to inappropriately use medical care in either direction. So skipping appointments or constantly, badgering the doctor, look at this, look at this, look at this, which makes sense if you're really anxious. And there's also some evidence that it corresponds with cancer recurrence and earlier death, although there are mixed findings on that for anxiety. And what do these look like in cancer for those of us not in the trenches with patients every day? This is a breast cancer survivor of triple negative breast cancer, who we got to know in one of our studies. And she said, I feel a lot of anxiety, and my usual ways of dealing with it are not working. I usually handle anxiety well by asking myself two questions. What's the chance that my fear will actually come true? And what's the worst case scenario? Couldn't I deal with that? Neither works for dealing with my fears about cancer. My type of breast cancer has a 50% chance of recurring. So the worst case scenario isn't rare and it isn't pretty, right? She's the mother of young kids, and she knows if her cancer comes back, it's almost certainly going to be metastatic, and triple negative, of course, doesn't respond as well. Historically speaking, doesn't have as good a prognosis as most other forms of breast cancer. So this is fear of cancer recurrence, and it looks lots of different ways, but I thought this quote was really powerful. And then there's also forms of existential threat. So for example, this melanoma survivor who we got to know, we've enrolled over 500 Colorado cancer survivors in our research studies over the last few years. So we've gotten to know a lot of patients. And this melanoma survivor, he says, I have no peace of mind and I'm still in shock. Like, did this really happen to me? Who am I anymore? I have no idea. And we see this a lot also, existential threat across all different forms of cancer. We've also seen especially a lot of it among non-smokers who get lung cancer. And of course, that is at least 20% of folks with lung cancer. So let's pause and talk about depression for a moment. So depression is most common in the first 2 years after cancer diagnosis. So whereas anxiety tends to be the long-term legacy of cancer, psychologically speaking, depression is the short-term legacy. And again, most folks still don't get full-blown clinical depression, but it's very common to have depressive symptoms. And the higher one's depressive symptoms are, it predicts lower quality of life. Really importantly, it predicts poor treatment adherence. A lot of our cancer survivors are on maintenance therapies that they have to take every day, like an aromatase inhibitor or tamoxifen. And being depressed predicts poor adherence to maintenance treatment or even cancer treatment. And anxiety also messes with adherence. And depression predicts more severe physical symptoms and side effects of cancer treatment, poorer cognitive functioning overall and within cancer, and possibly, like anxiety, cancer recurrence and earlier death. So now that we've established, what these phenomena are, why they're important, because they're linked with a lot of outcomes that a lot of us care about. Who are we talking about? I've already mentioned rough portions and prevalence, but how do we figure out who these people are? So screening for anxiety and depression, which I think are the most important forms of distress. What does this involve? Why is it important? It's important because it identifies who really needs help. My own research in cancer and lots of there's huge meta-analyses on this that have been replicated. This is a really robust finding, is that the people, and listen to this carefully because this is not what most of us believe, myself included, before I saw this, the people that benefit from supportive oncology interventions really are almost only the ones who are distressed. Let me repeat that. Offering broad support groups to cancer survivors who are not distressed, when you look across all studies, that does not show benefit. What shows benefit is targeting anxious and depressed, i.e. distressed cancer survivors. Those are the folks who are driving benefit in these studies. Why? Because they're the ones who need help, right? The most. A lot of folks sail through cancer and they're just fine. I've seen that. I'm sure you've seen it too. And I don't mean to poo-poo the experience of cancer at all, simply that, humans are impressively resilient. So we have to identify who needs help and direct our psycho-oncology resources, I think, towards those folks, because we all have limited resources, right? So by screening and seeing who mostly needs help, we can direct our limited resources towards those most likely to benefit from our offerings. And like I've already noted, not all cancer survivors benefit from supportive interventions. I have data on that from my own study and my own studies, and lots of other folks do too. So who benefits the most? I've already indicated those with higher baseline levels of distress, anxiety, or depression. So in other words, if you're screening folks and folks are saying like, yes, I'm distressed, yes, I'm anxious, yes, I'm depressed, those symptoms resonate for me, those are the folks who are likely to resonate from extra support. I've already noted these are often the only people who reliably benefit from our supportive oncology programs, and others, and even when everybody benefits from a program, the distressed patients tend to benefit more. The other people that benefit a lot from supportive oncology offerings are people with poor quality of life that may or may not have anything to do with anxiety and depression, and less social support. Those folks also benefit more. So basically the most vulnerable, psychosocially speaking, among our cancer survivors. So what is the best screening tool? There's lots of screening tools out there, but the gold standard from ASCO, which puts out evidence-based screening recommendations for anxiety and depression. The best practice there is the patient health questionnaire, the 4-item version, the PHQ-4. And there are 4 questions on this that any of us can ask at Rocky Mountain Cancer Centers. They used to implement this for all their patients in the Boulder office. And the first 2 questions are anxiety-based. So are you feeling nervous, anxious, or on edge over the last 2 weeks? How often have you been bothered by this? Are not being able to stop or control worrying. Okay, and we're looking for folks that score a 3 or above on this. And that is an evidence-based cutoff for, wow, you have clinically significant anxiety. And those are the folks who are most likely to benefit from our supports. And then these last 2 questions are depression questions. Over the past 2 weeks, how often have you had little interest or pleasure in doing things, or felt down, depressed, or hopeless? Hopeless is really important in cancer because there's a lot of hopelessness and despair. And again, 3 or more on this is an evidence-based cutoff for folks who benefit the most and really need help the most from our supportive efforts. So how to help, right? There are lots of ways to help, and many of you are coming from complementary backgrounds to what I'm going to report. But I think whether you're a mental health care practitioner or not, it's helpful to know what are some basic strategies to support cancer survivors who are reporting elevated anxiety or depression on this screening tool or otherwise, because you don't need to use a tool if people are telling you they're anxious and depressed. Certainly, that bears just as much weight. So there's a few categories that we can, of shifts that we can support cancer survivors in making. The first is shifts in actual behavior. So the first thing, and a lot of you probably already know these, but it's helpful to be reminded. The first thing is encouraging activation, doing fun and pleasurable activities. It sounds so simple, and yet I can tell you, I treated a woman we just finished up a pilot study of a novel written exposure intervention for late-stage cancer survivors who had high levels of trauma symptoms. And I treated a woman who, I don't treat a ton of my own patients on my own studies because of the conflict of interest, but on these pilot studies, I always treat at least 1 or more patients, so I know how the protocol is working. And the woman that I treated on that study, she was a late-stage cancer survivor, and she literally did not leave her house every day. She was so anxious, depressed, demoralized, discouraged, and traumatized. And she wasn't doing anything. And we got her through the intervention. She started going out every day, and it essentially, that alone lifted her depression. So this really is a huge deal for depression in particular, but it also can be helpful in anxiety because anhedonia, kind of loss of pleasure, loss of engagement in pleasurable things, is really common for anxious folks as well. However, here's the big but. I have a study right now in late stage ovarian cancer that we're about to launch. And that is a study on fatigue because, of course, the broader legacy of cancer treatment, the most common symptom among cancer survivors overall is fatigue. And so we have to be really careful when we encourage people being more active and doing fun and pleasurable things, activities in their daily lives, to do that in a balanced manner. So not overdo it and not underdo it. It's that kind of sweet spot of what can you do every day that you can sustain every day that's not going to then cause you to have to spend 2 days in bed recovering. And what can be really hard for all of us is it's really easy if someone becomes scared to just be like, oh, it's okay. I understand why you're scared, and kind of reinforce that instinct towards avoidance of whatever they're afraid of. But avoidance feeds anxiety. And so if people are afraid of, say, getting their cancer scan, if people are afraid of doing their breast self-examination, if people are afraid of taking their aromatase inhibitor, if people are afraid of doing treatment, I think, as an anxiety researcher, the worst thing we can do is indulge that avoidance instinct. The best thing we can do is counter that avoidance and encourage people to face their fears. Because when they don't, they avoid treatment or avoid really important areas of their life. So we are finishing up a study right now for anxious and depressed adults with metastatic cancer. We've enrolled 225 Colorado late-stage cancer survivors in that study. And I can tell you that a lot of the folks in that study, when the phone rings, they never answer it. They totally socially isolate because having a diagnosis of metastatic cancer is so stigmatizing, it's so isolating, it's so difficult to manage treatment and side effects and how badly it makes you feel, that their instinct is to just withdraw and avoid social contact. And that keeps people stuck in a cycle of avoidance and depression and anxiety. So the best thing we can do when we hear this, regardless of whether we're a nurse or an administrator or whoever, is to say, yes, I understand it is really hard to pick up the phone, but please, please, I encourage you to do so, because connecting with other human beings for most of the time it will make you feel better. And then last but not least, this has come up a ton in my work in late stage and early stage ovarian cancer, because a lot of those folks are on very fatiguing medications, is to encourage regular sleep and good sleep hygiene. So just the basics that we've all heard about: no screens an hour before bed, having the same bed and wake time every day, including on the weekends roughly, avoiding alcohol and caffeine in the evening hours, etc. So keeping lights low, all of those things, they sound so basic and so boring, but they can really make a difference. Not napping in the afternoon, even when you're tired, keeping your naps to short naps and doing them in the morning. These things can make a huge difference for cancer survivors. I've seen it in my work. I've heard it from our patients. So what about the mental components of anxiety and depression? How do we help people reduce worry, catastrophizing, and ruminating? So first of all, of course, we want to normalize and validate, because those are super common human experiences, regardless of whether you have experienced a cancer diagnosis and treatment. But an evidence-based strategy that I think we can encourage people to use, regardless of whether, we're therapists or not, is to designate to encourage people to do what's called designated worry time. So designating 15 to 20 minutes per day or every other day or a few times a week, depending on how severe the worry is and how frequently it comes up, of time to simply write down all of your deepest, darkest worries in one place. And then every time worrying comes up during the day, you say, oh, okay, save it for the designated worry time. At 5 o'clock today, I know I'm going to get to indulge all of my worries. I'm going to get to write about this then. And then it just helps people to not engage in the worrying behaviors as much outside of that designated worry time. Another strategy that I was just reading in the literature, which is an evidence-based strategy, it's a little bit more advanced, but I think it's kind of cool, is to encourage people to replace worry images, like of worst case scenarios, with imagining realistic positive outcomes, not in a Pollyannish kind of way, but they can rehearse like, okay, I actually think I would be okay in the future, and here's why, and here's what I'm imagining. And what we know from lots of research coming out right now on positive affect therapy and training is helping cancer survivors to identify future positive events that they're looking forward to and encourage them in the here and now to imagine and look forward to those events and really positively anticipate them, and then to savor them while they're doing them, and then to remember them, make a photo album, take pictures, revisit that photo album every day, whatever it takes to really anticipate, enjoy in the moment, and then hold on to the memory of positive events. That is a very powerful counter and science-based backed strategy for countering anxiety and depression symptoms. And then, of course, we want to encourage them to bring specifically their fear of cancer recurrence, fear of cancer progression concerns to their cancer care providers and ask their providers, what am I supposed to look for to know if my cancer has recurred or progressed? How am I going to know that? How often should I check for that? And then encouraging them to stick to that. Because for some cancers, there really are no warning signs. And so the doc will say, hey, you're getting scanned every 3 months, or you're getting scanned every 6 months. That's all we can do. And it is not, we're going to catch it if it's there. So you do not need to worry between scans. Or maybe they should be doing a self-exam in certain ways. They should know what that self-exam is, what signs they're looking for, when to call the doctor, and how often to check. And just those basic facts of information from their cancer providers tends to help people obsess less and feel like they're doing whatever they're supposed to be doing to prevent recurrence and prevention. So in summary, anxiety, depression, and related symptoms are very common among cancer survivors, but again, the majority of our cancer survivors do not meet criteria for an anxiety or mood disorder. Depression is the most common in the first few years of cancer survivorship. Anxiety does decline over time after treatment in early stage cancer survivorship. In other words, cancer survivorship for folks with early stage diagnoses, but it does remain elevated for a really important subgroup of patients, survivors, and caregivers for a very long time. These are distinct but overlapping phenomenon, anxiety and depression, but they are very easy to screen for. And there are very straightforward strategies that we can all use to support our cancer survivors to reduce symptoms. And that is it. That's all I have for today. And I'm happy to discuss because I'm sure that y'all have seen lots of mental health phenomenon in the cancer domain and in lots of folks. These are really common phenomenon in general within and outside of cancer.
Joanna, thank you. That was fantastic. I want to open it up. If people have questions or thoughts, you can turn your cameras back on or even just put something in the chat. But I think that was just really great, useful information, and I think relevant to a lot of what our task force members are doing and maybe can even do more to enhance. So go ahead, if anybody, please.
Ask away. I love questions. And if you have it, I guarantee you're not alone. So don't be shy.
This is Jeanette over at Lutheran. I do have a question on the distress or the depression type screening model that you showed. Mm-hmm. When have you found the best time to apply those type of screenings are throughout treatment? You know, the standard of practice for some of the distress screen is at beginning of mm-hmm. treatment, but that looks like it would apply throughout, you know, without wearing the patient out of, I've got to fill this screening out again.
Totally. I think that's a phenomenal and really important question. And I'm glad you asked it. I think the gold standard now is, like you said, at the beginning, but it is also at critical shifts in care. So for example, at the beginning, and then right before they start treatment, when they've ended treatment, I would argue is also a very important time to ask, because what we're seeing is that a subgroup of patients power through. I'm sure you all have seen this, power through treatment. Oh, I'm fine, I'm fine, I'm fine, because they have a goal. These are often the achievement-oriented types. I can't relate to that at all. I'm kidding. They are powering through treatment. They have a goal. They have a schedule. They have a whole support team of cancer care providers. They have all the people like you who are working to make their lives better. They are doing awesome. And then they finish and they're like, oh my God, what just happened? Holy camole, right? And so I think we often miss that key screening during the survivorship phase. So I would actually say if you're going to screen twice, I would screen at the beginning and when they enter survivorship, but I would prefer to see screening happen at major shifts in care also, just because there's so many moving parts with cancer treatment for many of our folks. Yeah, great question. Is that helpful? Yeah. Okay, great. What else?
Sorry, I was still muted, but yes, very much. Thank you.
I had a question about what types of supportive interventions. You mentioned that they only really help the people who are really distressed.
That's who's driving the benefits that you see.
Yeah.
Sorry, go ahead.
So what are the supportive interventions that you were looking at there?
Yeah, so that's a great question. Those data refer specifically to psychosocial supportive interventions. So things like cognitive behavioral therapy or acceptance and commitment therapy or structured support groups. Those tend to work best for the people that benefit from those really the most are folks who are distressed, anxious, or depressed, even simply modest levels of elevations in that. So for example, if you're using the distress screen thermometer, the 0 to 10 or 1 to 10, we usually for our work have a cutoff of a 4 or a 5 on that for how distressed they are now. Or I think what's important for cancer survivors, especially folks who are done with treatment, they were treated with curative intent, they're done with treatment, they're cured for now, hopefully for forever. Those folks, I think what we learned is that often they're not super distressed in the moment. So they'll say, oh, I'm a 2. But if you say, how distressed are you thinking about your future now that you've gone through this? That is a really important question for cancer survivors because a lot of them are okay right now because, oh, phew, I'm done with treatment. Like I'm recovering, I'm doing okay. But then when they think about the future and they're like, oh my God, I'm a parent of 3 children. What if this thing comes back? I feel like I'm at a 6 thinking about that. So you have to assess both now and for the survivors, how they feel about their future. So yeah, and I think that folks who are elevated, like a 4 or 5 or above on a distress thermometer, or a 3 or above on either of those anxiety or depression screeners I showed, those are the folks that are really driving benefit from psychosocial support groups. Now, something like cannabis or exercise, I think everybody can benefit from exercise. I don't know the literature on cannabis, so I'm not going to make a statement that isn't evidence-based for that. But, I'm really talking about psychological interventions. You really want distressed people doing those if you have a limited number of spots. If you can offer it to everybody, sure, why not? But if you have, a few support groups and a pretty decent amount of demand, those distressed folks are going to benefit the most.
I was going to say more a comment, and probably this would be, I think Dan would be interested too. So I have a nonprofit for adult cancer survivors, longtime partner with UC Health. So
nice.
We offer outdoor camps, and I hope you're aware of us. I know Carlin is a big, and Jeanette knows about us, because what we see, we do not an actual study, but after camp, our one question when we do a survey is, do you feel your mental health improved? Because there's parts of what you said I go with, and I get you're in the hospital studying it. We would say what we've seen in 12 years that probably 80% of people, when they come to camp on a week-long and in-depth conversations with other survivors, would say definite anxiety, a lot of depression, a lot of medication. But after a week, or like people going with Dan on his weekend programs, I would think he feels the same way we do. It's a huge shift in their mental outlook.
Totally.
Not that
I could
anything
see
goes
that.
away, but it would be an interesting study. We've tried for years to kind of include what Dan's doing in that outdoor arena, what we do. It's tried to be studied in a simple form because I
Yeah,
think it takes it in what I've witnessed to a whole new level of, psychologists and social workers are amazing, but what we hear a lot of people too, they don't want to go back in the hospital for those appointments because
that's
that
right. That's
triggers
right. It triggers
anxiety.
exactly. Well, so
Yeah.
what I would say, honestly, is Nancy, you probably are attracting those people to a program like that. Because if you're doing just fine after your cancer experience, you're not going to sign up for a week of,
No, they still sign up too.
oh, they do. That's good.
We have
That's good.
spanning the globe.
That's
So
awesome.
some would definitely benefit. I mean, we share that with people. We have some that are in like, still when they get with us, and some that we have people that join us 50 years out that think they were okay
That's
and
amazing.
realize not so much.
That's amazing. But
Yeah.
again, those interventions are not the kinds of interventions on which that claim is based.
Right. I
Those were
understand.
really
Yeah.
psychological support groups. So I
Yeah.
think for interventions outside of kind of that are non-traditional interventions like camps or outdoor bonding and conditioning, physical conditioning in nature, that I don't think we have studied those enough, and I could totally imagine
Yeah.
a broader audience of survivors benefiting from those because they're hitting on much broader things, right?
Right. Right. And you have the time. It's not just limited to an hour or two. We have an entire week. We have an afternoon. Dan has a weekend, the same kind of thing.
Totally. Well, and there's a
Um,
strong relational component and there's a strong physical component.
absolutely.
And so you're hitting on, just a lot of different domains other than the ones that I was hitting on here. I
Right.
love that program. That sounds awesome.
Yeah, but would love to somehow work with you someday to show what Dan's doing, what we're doing,
Yeah.
the impact that has. It is that outside different layer.
It sounds like amazing work.
Hey Nancy, I added a link to a research study in the chat on
Yay.
and it's new, it's 2023. So there is
Oh,
research.
Very cool.
thank
So
you.
yeah.
That sounds awesome.
And I do want to add that NCCN just published a study that I think is also interesting, talking about very specifically looking at isolation and loneliness and cancer mortality, leading very heavily on the community supportive interventions and why they should be definitely those referral sources. I mean, there's traditional support groups, right? But it's very different to have a traditional sit around the table support group. And I remember starting at my early career as an exercise professional, that wasn't always the audience, right? Like to sit around the group. Like those are the people that didn't always want to move, but if we could get them out of around the table to those interventions, they were more interested. But it is the community side. So I thought that was some pretty powerful research. I'll actually put that in the chat too, because it really does support both of the work that you are doing, Nancy and Dan as well. So anyway, some good
Yeah, I
stuff.
love it. And that speaks to that low social support group that I alluded to at the end of being one of the most vulnerable groups of
And it
cancer
would be
survivors.
another interesting test or study, Joanna. So I think about all the people that come that we constantly hear. I went to one support group. My son's a cancer. He went to one and was like, no way. He was 23. Everybody was old, but even still, we've heard that for years, not even an age thing. But to study like we have hundreds of people that have joined us. It's like, have you done a support group? What was good? What was bad? Would be an interesting thing to help make it all better.
I agree. I agree because I think you're tapping at something really important, which is that there's really diverse preferences for the type of support that people want and that matches who they are and what's going to benefit them. And support groups are clearly not the only, fortunately, thanks to a lot of you all, for not the only offering in Colorado.
Well, like we say, we're not the right fit for everybody either. So it's like, how do you let everybody know all that's available and so they can find where they want?
Well said.
Joanna, this is Jeanette, and I have a question on it. The specific population you're talking about, I completely agree. We see that same, it would reflect in what we see as far as people who seem to need or the interventions the most. I think the challenge is, and I don't know if you have suggestions on better scripting for staff or better introduction to programs, is how do you get those people to come to things? Because they're also the people who are most likely to no show or to say they want to come and then never come. And a lot of times, once I would say, once we can get some people even to a group or even a support group, they tend to come back. Many do like that are looking for it,
Yeah.
found a little
Yeah.
benefit, but it's getting them to come and try it. It is not for everybody, I agree. But for those who it will
Who
help,
really
I
need
think
it.
getting them there is the hard part. And we're all struggling, especially in a post-COVID world, with now the disconnect where virtual group may not really give them what they need.
Yeah, that's a great question. I'm sure that others in this group have great ideas on this. Um, what I'll say that our social work team that I work with does a lot of what my team does. We had to move everything online during COVID, of course. And I actually think for our rural folks, that has been a huge boost to their ability to attend because we used to have people driving in 2 hours, like from Estes Park or from other, not near big cancer center areas of the Front Range and beyond. And so I do think that online isn't for everybody, but I do think for a certain group, it lowers barriers to access. And then if we're thinking that somebody's not going to show up, sometimes the social workers will schedule a time to meet with them right before the group and then they just walk over together. Some, or they're like, okay, we're going to have a meetup and you'll introduce them to another survivor who's going to do the group, let them exchange numbers and say, okay, the two of you, do you guys want to meet up before? Like, so I think a lot of it is those relationships and accountability through relationships. Like, oh, I know this person, they're expecting me to attend. I better show up. Or I have an appointment. I'm not going to stand up my provider. I better show up. And then you just go over there together if it's an in-person group. So that can lower barriers. Because one of the things I didn't talk about today, but that I have done a lot of research and clinical work in is social anxiety. Social anxiety disorder, other than little phobias of things like dogs or darkness or lightning, is by far the most common anxiety disorder. And there's a lot of symptoms of social anxiety, even for folks that don't have the full-blown disorder. And those folks are going to have a really hard time, especially initially coming to group. And that's a very common form of anxiety. So I can't emphasize enough how right you are, and that anything we can do to lower barriers through relationships, through access, through other things, providing food, etc. Increasing the size of the carrot and reducing the barriers.
Yeah. Hi. My name's Rebecca. I got to give a plug for occupational therapy here because I was able to offer one-on-one billable time with folks navigating exactly the things that you're talking about.
Yay.
And one of the great resources I had was, Live by Living and these programs that were good matches, for the folks, because we have to be so client-centered, right, in how we connect and what we offer. But I wanted to say, in my, I didn't do a research study, but I observed that when I had patients referred to my program who already had a chronic mental illness, they had a long history with depression or anxiety. The services that I could offer that really worked for people going through cancer who experienced anxiety and depression after the cancer were not efficient. I was not there to be a psychotherapist for people who needed somebody before cancer, if that makes any sense. So I think there's a distinction between folks who are starting to experience depression and anxiety after that cancer diagnosis, or it's been mild in their life and it's coming up because of the cancer, versus some people who've had really chronic conditions. And the
For
services
sure.
that are really, really different. Yeah.
Absolutely. Absolutely. Yeah, I think that's really important. There is a distinction for sure, but yes, yes. And I think I think all professionals, and especially those like in your case,